So arrived in Port Vila, I was handed a set of keys and we've secured you a building for the station and here's a checkbook and a bank account. There's no money in it. Now go run an ambulance service.
Before the Hospital, the podcast for evolving EMS systems. Your host is Hamish McLean.
Vanuatu is a chain of around 83 islands in the South Pacific, roughly 1,750 kilometres east of the Northern Australian coast. About 65 of those islands are inhabited by a population of little over 300,000 people. Today's story takes place in the regional capital, Luganville. Andrew, welcome to EMS Global's podcast, and we are looking forward to the discussion that's going to look at your involvement in setting up an ambulance service in Vanuatu.
Thanks, Hamish. Thanks for the opportunity to come along and speak to you today.
Andrew, you were in Victoria as a paramedic. How did you end up in Vanuatu building an ambulance service?
It's a great question. I'd spent some time in Vanuatu volunteering for a medical clinic, and my wife's a school teacher and she was working in a local school. And through that experience, we bumped into the National Operations Manager for ProMedical, which was a non-government charity ambulance service in Port Vila, which is the capital, and got to chatting and Mick was his name, and he's like, oh, I'm an ex-Ambulance Victoria paramedic. Next time you come over, why don't you work for me? So for a couple of years, I volunteered my annual leave block working with the crew in Port Vila, and then the opportunity to establish a new station or service on one of the other islands became available, and we jumped at that opportunity. So we fell in love with Vanuatu the first time we went over, and then that relationship grew over the years we were volunteering, and then there was the chance to go over full-time and start a new station and a new service.
So what did that entail? You just describe or walk us through the area that you set the ambulance service up and why that particular location and the steps you took to establish it.
ProMedical had been receiving some support from the Australian government through the AVID program, the Australian Volunteers for International program. Funding became available for a AVID position on the island of Espiritu Santo. So Espiritu Santo or Santo is the biggest island in Vanuatu. It has the regional capital of Luganville, which is the second largest population centre, and there was the opportunity to introduce a service over there. So I was asked to take the AVID position and then head over to Santo and commence operations over there. There was also strong support from the community on Santo for pre-hospital or out-of-hospital care operations. So they had seen what was going on in Port Vila with ProMedical, and they wanted similar operations for the community over there as well.
So what year was this?
2014. So I went over in 2014, so there for 2 years, 2014, 2015. Knew the position was coming up, so the funding had been approved back in 2013. So I actually had a lead-in time of about 12 months before the position started. And that was really important time. ProMedical is a non-government charity ambulance service. So there was no funding in terms of setting up for equipment or vehicles. So I actually spent 2013 in Australia fundraising, for want of a better term. I contacted every ambulance service in Australia, writing letters to their commissioners or CEOs asking for support. I was at one of the Australian Paramedic College conferences. I actually ran into the owners of Neon, which is the company that creates all of the equipment bags for the services around Australia. And I just got chatting to them at their stall, talking about the fact that I was about to head to Vanuatu. And they said, oh, next time you're driving past our factory, which is in Geelong, just outside of Melbourne, they said, drop in and say hello. So dropped in to see them, and they said, open the boot. And I opened the boot of my car, and they loaded my car up with equipment bags, oxygen kits, drug kits, oxygen cylinders, oxygen regulators, spine boards, neck collars, all of these pieces of equipment that services had, like the first iterations of gear bags that services, were trialing that didn't get up. And so they just filled my car up with donations. Wow. And that was the start of the service. And then the big one was Queensland Ambulance Service. So the commissioner reached out and said, we'd like to donate a vehicle. And this was huge because I had no pre-existing relationship with QAS, but they donated a Land Cruiser troop carrier ambulance, and that was it. We were off and running. We had the gear to fill the vehicle. We had some, BP cuffs and thermometers. And then obviously Ambulance Victoria and the local stations around the region I worked then started donating some bits and pieces as well. So it was that small trickle to start with, and some, individuals and companies in Australia that liked what was happening and they got on board, and that was how ProMed Santo started.
That's an amazing story, and also a lot of coincidence and serendipity thrown in there as well.
Absolutely. Oh, absolutely. I'm not sure what we would have done if someone hadn't got on board with a vehicle. It was after that it just started to feel real. I was really looking forward to the next challenge of actually getting there and starting. So,
all right, let's just one step back from that then.
Yeah.
If I had an accident on that island with a fractured leg and all those sorts of things, what would have been my treatment, or how would I have got to a hospital? What would have happened to me when there was no ambulance service?
That's a great question. And one of two things would have happened. So the hospital there, Northern Provincial Hospital, did have a vehicle. It was a troop carrier with a stretcher in the back, and that was it. There was no equipment. There were no trained personnel. They would have found someone in the hospital who could drive, and they would have driven to where you were, picked you up, put you on the bed and driven you to hospital if it was available and if it was within business hours. If it was after hours, it would have been trying to arrange a local transport, and that either would have been a minibus or a dual cab ute, and they would have thrown you in the back of that and driven you to hospital. And that was the level of out-of-hospital care available on an island of a population of 30,000 people.
So certainly you would have made a big impact in the pre-hospital care of the 30,000 people who live there, and I guess tourists as well. So
absolutely.
You've arrived to set up your ambulance, you've got your vehicle, and you've got the equipment.
Yes.
What were your next steps? And of those steps, what were the biggest challenges to get this operation up and running?
So arrived in Port Vila, I was handed a set of keys, and we've secured you a building for the station, and here's a checkbook and a bank account. There's no money in it. Now go run an ambulance service. So,
and at that time, did you think about going back to Australia?
I definitely knew it was going to be tough, but I didn't realize what it meant to do this. I probably went in a little naive to the realities of it. I mean, I was a paramedic. I'd worked in an Australian, paramedicine system where if you needed something, you walked into the officer in charge's office and said, "Oh, we've run out of stuff. We need to order this," or the car's making a funny noise. Oh, no worries. We'll just get on to, the mechanics or the workshop to come and fix it. There appeared to be an endless bucket of money. I got paid every fortnight. I didn't have to worry about where that was coming from. Moving to Santo and getting off the boat in Santo and unloading the ambulance, there was no money. There was nothing. And so it was, how do I keep this operation running? So first of all, I needed staff. I couldn't run ambulance operations by myself. So we did a call and we put an ad out, and we were looking for nurses or people who had medical experience to transition to this new idea of out-of-hospital care in Santo. We selected 2 nurses to be our trainee paramedics, Avong and Jerome. And the next step was then securing finance. And as basic as that sounds, it was walking down the main street of Luganville and knocking on every door of every business and introducing myself and saying, "Hi, Andrew, this is ProMedical Santo. We would love your help." And so it was about donations or providing sponsorship. And so we developed a sponsorship package. So, a couple of tiers. So if you provide this amount of money, we'll do this, this, and this. And so our tiers were around advertisements, and the ambulance essentially became a billboard. And I know that might sound funny from people coming from a high-income country ambulance service, but we needed to thank those businesses that came on board. So if you donated a certain amount of money, you got a big sticker on the side of our ambulance. We would provide first aid training to your staff. and we would also provide ambulance cover. So being a charity, ProMedical is a fee-for-service ambulance. If we come out, we will charge you a fee. And so we would then offer a subscription service. So if you donated, you would get, free cover for you and your staff for this period of time. So, and then the other side of that is if they didn't sign a sponsorship deal, they just might have donated some equipment or something, and we would hold raffles or, silent auctions, things like that. So the first couple of weeks was lots of door knocking, lots of hitting the pavement and getting support. We were lucky. There was obviously parts of the community that really wanted us there, and they got behind us from the beginning. But the biggest, win in that first month was a local petrol station donated free fuel. So our fuel bill was covered. They were a Pacific Petroleum. They were our first big sponsor. Anytime you want, just come around, fill up. This is how we're going to support you. And it just sort of snowballed from there.
From those early days, you must have gained a bit of confidence that this is going to actually turn out for the better.
Oh, yeah, for sure. Yeah. And once you started getting people coming on board, it felt great. We positioned ourselves as a professional ambulance service. We wore a uniform, and everyone knew the ProMed truck when it drove down the main street. So it was that visible presence as well that was really important. The next step was then getting the community to understand what we did, and that was like the next part of the journey. Yes, we needed money to run ambulance operations, but then we needed to teach people what ambulance operations were because they'd never seen it before. And so it was, well, okay, great, you're in a shiny new ambulance and you've got great uniforms, but what do you actually do? And that was the next big challenge for us in teaching the community what out of hospital care is.
And I guess part of that is also that the ambulance is available and how to contact the ambulance rather than trying to take the patient in the back of your ute to the hospital. How did you get the community to understand what you were doing?
A lot of community events. So, Vanuatu loves a public holiday. And so typically when there's a public holiday, there's a big event. So Independence Day, they do big celebrations and they have live music and food. So we would set up a stall and, we'd have the ambulance down there and people could come up to us and we had stickers, ProMedical, Santo, our contact number was 115. And so 115 keeps you alive, something catchy. Put it on a sticker. Here you go. Here's a sticker. The other big one for us was getting into the schools. So part of the subscription service that we introduced, we also had a school subscription. So for a certain amount of, money each year, the schools would get cover for their students and their staff. But we would then go visit the schools and talk to the kids about some basic first aid. But also this is an ambulance and this is why you call an ambulance and this is how you call an ambulance. So, getting to the kids. We would volunteer to have an ambulance on standby at sporting events. So there's amateur boxing in Santo, there's soccer, they've got their annual rodeo. So we would volunteer, park the ambulance, and so we were visible. So it was about that visible presence, and then people could come up, have a chat, and we could teach them more about that. I remember one of the funny parts of that, we did a radio segment. So there was a local radio station and we did a radio interview and we spoke about ProMedical Vanuatu and this is the number you call and 24 hours a day we'll answer the phone. I remember one night, it was like 11 p.m. So Vanuatu doesn't have a centralized call center. If someone rings 115, it goes to the mobile phone in my pocket or one of the other paramedics. So we get the call directly. And so it was like 11:30 at night and the phone rings and I pick it up. So, ProMedical, Andrew speaking. What's your emergency? Oh, no emergency. Oh, okay. Oh, I heard your radio interview today and it said you'd answer the phone 24 hours a day. So I just wanted to see if that was true. And I'm like, it is true. It is true. Yes, I will answer the phone whenever, but the phone is for medical emergencies. Okay. I just wanted to check if that was real and hung up. And it was like, well, I guess they listened to the interview, but they just wanted to make sure that, okay, this guy is going to pick up the phone 24 hours a day.
I guess the next step in this conversation is you are out there, you are answering the phone 24 hours as demonstrated by your example.
Yes.
Call numbers must have started to increase, I guess.
Yes.
What was the volume rate of your the calls to the service and the types of cases that people were actually calling you to?
Slow to start with, and then a confusion, maybe, people not sure what we could do. So they would ring sometimes for things that an ambulance service normally wouldn't attend to. I've got a cold and a runny nose. What do I do? So again, building that education in the community. Like initially we didn't say no. We got out. If someone rang, we would turn up and we would have a chat. Education. It was that visibility thing. As we more visible, yes, our call numbers increase. And we're not talking cases per day. We're talking cases per week, So we were doing maybe 4 or 5 cases a week. And while that doesn't seem a lot, it was big for us because some of these cases, they were increasing in complexity. And one of the things about Vanuatu and potentially other low and middle income areas is the smaller health centres located in, so Santo's an island. So yes, there was a Northern Provincial Hospital in Luganville, but there were lots of small health centres and dispensaries dotted around the island. And we were the transport link from those health centres back to the Northern Provincial Hospital. And I remember one case, and we were called to help one of these outlying centres to a patient that they'd been there for a couple of days, and they were deteriorating rapidly, and we met them en route. And this is the thing. So they'd started transporting this patient in a dual cab ute in the tray of the ute, and we arrived and met them on the side of the road, and the patient is sitting up in a plastic chair in the back of the ute with a nurse holding a mask on their face. And, so we obviously took over care, but the patient was critically unwell with sepsis, and they'd just been sitting on this patient at the clinic for 3 or 4 days, not knowing what to do. So, there was this increasing complexity in the cases that we were being called to respond to because we were that link. We positioned ourselves as a professional ambulance service, and we were running to international or Australian levels of care. So people were beginning to understand that the service we could offer. And so complex cardiac cases. Sepsis was a big one, and sepsis and seeing the types of injuries and illnesses in those outlying communities that people were dying from was what prompted the next step in the development of our operations in Santo.
What was that next step? I'm imagining that your ambulance is becoming busier and more demand, and you've got one vehicle and a limited crew, and also distance between these clinics and the hospital.
Yeah.
So your ambulance could actually be unavailable for other calls. So what was your next step in continuing to meet that demand?
Yeah. So the next step for me, and I thought it was a logical step at the time, was a community first responder program. So I think that there were 2 cases in particular. Number one, it was this sepsis case. The second one was, it was actually 2. It was the same day. We were called to a small child that had been hit by a car crossing the road. And we arrived on scene, and the local police were there, and they said, we threw them in the back of the truck and we drove them to hospital. And I'm like, okay. So we followed up at hospital, and the child had a compound fractured femur, and so it's obviously a significant injury anywhere in the world, but in a low resource setting like Vanuatu is a very, very significant injury. While we were there, another car pulled up at the front of the hospital, and they brought this patient in who was using a angle grinder, and the blade of the angle grinder shattered and had hit the patient in the thigh and had severed their femoral artery, and they had an arterial bleed, and they put on a makeshift tourniquet. And this just sparked something in me and said, we're here. Maybe we need to be looking at empowering the community to do some basic first aid as well. So then that's sort of where we call it the VFAR, the Village First Aid Responder Program, was sort of born from, if we can't get there, or before we get there, what can the community, what can the layperson do to support the injured or the unwell? And you think about first aid in Australia, and it's like, lots of places teach first aid, but in somewhere like Vanuatu, first aid, particularly in those remote villages, is not readily accessible. So that was our sort of next step, is like, what can we do to empower the community to look after people before definitive care gets there, or they can move the person to definitive care, whether that's a clinic or a post or something like that.
And how successful was that program and doing exactly that, either treating the patient before you arrive or taking the patient more safely to a clinic?
I think it was very successful. We applied for something called the Direct Access Program, which was funded through the Australian High Commission in Vanuatu. So we put together a proposal for the Direct Access Program, and we won a small grant, and that grant enabled us to teach 200 people in multiple locations community first aid. So in conjunction with, the paramedics, the Ministry of Health and the Department of Rural Health, we developed this program. We targeted villages that didn't have direct access to an aid post or a medical centre in their village. And then we went out and delivered our first aid training program or village first aid program in these locations. And it comes with its own set of challenges. Vanuatu doesn't have a great mobile phone infrastructure. So reaching some of these villages was actually, we drove to them and introduced ourselves to the village chief and said, we're ProMedical. We'd like to, like you to consider this program that we're doing and let you think about it. And then we'll come back in a week and, see if you've decided to get on board. It was quite a process in itself, getting the village first aid program off the ground. So, and as part of that process, I at the time thought, maybe we should track this. Maybe we should look at whether this makes an impact. So at this time, I'm a paramedic. I'm not in academia. I'm not a researcher. I don't know much about research. I just had this question in my head that if we test people's first aid knowledge before, then we teach them first aid, and then we retest their knowledge after, I wonder if there will be a significant difference. And that's the way we developed the program. We did a one-day first aid course that was taught in Bislama, which is the national language of Vanuatu. And then we retested their knowledge afterwards. All of our information was translated into Bislama. Interestingly, literacy rates in some of the remote locations wasn't high. So yes, while we did have printed material, we relied on practical demonstration and also diagrams in our material. And then all of the first aid questionnaires were translated to Bislama as well. So it was about being contextual and culturally appropriate, and the questions and the way we designed the program, obviously in conjunction with the Ministry of Health and Department of Rural Health and then paramedics, we made sure that what we were doing was contextual and culturally appropriate as well.
So you're really progressing there on getting the community educated on being first responders?
Yes.
You've got your ambulance paramedics service running. What was your relationship then with the government and with the Ministry of Health? How did you build that relationship and be accepted by them that you are there to do good, if I can put it that way? On
a local level, it was getting to know, obviously, the superintendent of the hospital. So, building that relationship with the Northern Provincial Hospital was important. And that was a very strong relationship. And that was built through being available and being visible. And then a lot of it was just knocking on doors and saying hi. The local Department of Rural Health, dropping in to say hello. How can we help? Is there anything we can do? It was just building those connections.
So it seems to me that you weren't really looking at contracts and memorandums of understanding. It was really built around interpersonal relationships. It's built around knocking on doors, and it's built around who knows who and who can help who. Would that be a fair estimation?
Very much so at that local level. Yes, we can talk about memorandums of understanding, but if you don't have that local relationship and that local buy-in, I think then it makes the process more difficult. Maybe that's a lesson, is having interpersonal relationships and having local buy-in helps you then build or scale. Because if you don't know the boots on the ground, then I don't think you can build those bigger, sustainable relationships.
I'm interested to know why you set it up as a paramedic service and it wasn't BLS, it wasn't EMT. You went sort of to that paramedic level. What made you go there rather than a different sort of level of service? Why paramedics?
Simply because that's what I was. My experience in Australia was at the paramedic level. So, I mean, I started my career in 2001. So obviously that's before registration, and I didn't have much experience with the EMT level. So I didn't actually quite understand what it was. So we essentially took the Australian model and moved it to Vanuatu and attempted to upskill our local paramedics to that level. And, that probably in hindsight wasn't the best approach, because I had the privilege of education and an established ambulance service and established education guidelines to help me build to that level where, Vanuatu in particular didn't have the infrastructure around developing out-of-hospital care systems. It was naivety, probably more than anything, that we just went down that system. So hindsight's great. We probably recognized that a little bit later. And then I think that's where, ProMedical's moved to now, looking at EMT, BLS training or structure. So obviously Australia, the UK, New Zealand, we have registration, we have paramedics. I imagine that will come to Vanuatu one day, but also the question is that the best system for that context?
And that's something that's very important is the context of where you're trying to provide that service, right? So in your experience, how important is context in an LMIC environment?
Context is everything in an LMIC. Context, it's a multifaceted context as well. Culture, language, religion, history, all of these massive layers of context. And sometimes they're difficult to understand and navigate. A couple of examples, like I remember developing the community first responder program, and I didn't think we should include CPR. And that was just Andrew being a pragmatist. At the time, cardiac arrest survival rates, even in high-income countries, was fairly low. Then understanding that even if you got someone to hospital in cardiac arrest, the hospital in Luganville didn't have the resources to deal with, intensive care and reperfusion and things like that. There was no intensive care unit. So look, let's concentrate our efforts somewhere else. And my colleagues were like, oh no, Andrew. They didn't call me Andrew, they called me boss. And another part of context that I had to learn to deal with. No, we have to teach CPR. Yes, we know that survival rates are low, but in the context of the village, they need to know that something was tried and an effort was made, and that will make the people of the village feel like at least we tried. And that sort of opened my eyes up to, okay, I'll take my pragmatic ambulance brain out. Let's look at this in the context of a village. So, that was one thing. But then culture is such a big thing as well. And I remember, one of my paramedics, saying we got called to a job, and it's like, Andrew or boss, I can't go in. Sorry, what do you mean? She says, oh, this is my uncle. Culturally, I can't stand in front of my uncle, like I can only walk behind them. So, there's these little cultural nuances as well, and it was just trying to come around that. So context is so important. The other parts of context are, how do you receive a call? How do you receive an emergency call? There are no street names in Luganville, and then there are no roads in villages. So the context even of just simply receiving an emergency call and dispatching an ambulance, there's no central dispatch. So someone would get the call, and then they would call the other person on call, and then we would drive. And I'm not a botanist. I don't know trees, but the directions were head out of town on the hard seal road for 2 kilometers. When you see the big mango tree, take the next left on the white road. So they use crushed coral for roads. So I don't know what a mango tree looks like at daytime, let alone nighttime. Yeah. So that local context of, don't worry, boss, I know exactly where that is. That's next to Bob's house. And it's like, if I didn't have that local context, or yes, I've been given a village name, but that village is an hour and a half up in the mountains. I don't know the roads. So, simple contexts around that. And then learning to understand what job types we attend to. What are the most common jobs we attend to? Is our treatment or protocol appropriate for this context? So we started developing some local guidelines and local protocols around the most common types of, diseases we saw. Respiratory diseases, asthma in particular was really big. Did we have drugs? Could we get equipment and supplies? Do we need to shift to something else because I've only got 5 nebulizer masks and they're single use only? So do I need to look at the context of how we treat certain conditions? Do mild presentations of asthma need a nebulizer? Can I use another treatment modality? So there were lots of contexts and how they all interplayed is a challenge in those types of environments.
Another interesting facet of all this, I think, is the post-Soviet nations and their efforts to change from the Soviet model to a hybrid Western Soviet model. And we're finding more and more that their solution is spending money on ambulances and not spending money so much on EDs and hospitals. So, for example, one country, they've got a very good ambulance service, high level of care, and then gets the hospital front door, and everything goes downhill from there because the hospital can't maintain that level of care. How was it for you? Because if you're operating a paramedic level service with standards equivalent to Australia or aiming to be equivalent to Australia,
yes.
How do you then match that, the care that they receive once you arrive at hospital and in the ED?
That was at times one of the most difficult parts of the whole process. There were often times where I was the highest clinical level on the entire island. So there may not have been doctors available. They might have gone down to Port Vila for training, or they might have gone to their home island for something. And so there were often times where I was the highest clinical level person on the entire island. And so it became difficult. The hospitals were very protocol driven, and no, we need the doctor to do this and we need the doctor to do that. Sometimes I would have to use my equipment and my resources to continue management in a hospital until we arrange for transfer to the primary receiving hospital in Port Vila. Other times it was, there's no advanced level of care. There was one ventilator, and that was for the operating theatre. There was no intensive care or even high dependency units. There was no CT scanner. There was a film X-ray machine and a handheld ultrasound. So if someone had stroke-like symptoms, there was no CT scan. So it was having to consider that. I get my patient to hospital, what's the next step? And that was probably the biggest personal challenge for me, was trying to reconcile that, yes, we're trying to operate an Australian standard, but that standard may drop slightly when we get to hospital. And that's certainly no reflection on the care and dedication of the medical staff at the hospital. It was just the constraints that they were under within the context of the Vanuatu health system.
Vanuatu is made up of 83, I think it is, islands, and there was responsibility placed on your organisation to do medical recalls across all those islands, and I guess including tourist areas as well.
Oh, 100%.
What were the challenges for you in those remote islands, getting to the patient and then getting the patient to definitive care?
ProMedical doesn't own aircraft, so we would partner with local aviation companies. So there was a relationship that we had to forge there. Those companies came on board readily. They wanted to serve their communities as well. Understanding that aeromedical retrieval in Vanuatu is not the same as aeromedical retrieval in Australia or the US or high-income countries. It's the locally trained paramedic. One pilot, one patient is essentially aeromedical retrieval. It's more facilitating the movement of critically unwell patients from those smaller islands and clinics back to Port Vila or Luganville Hospital. The level of care was just essentially the same as what we were providing in a truck, but this was now in a plane. Air traffic control on these little islands, there isn't one. So you've got to have absolute trust in the pilot to get the plane down on a grass runway with kerosene cans on the side of the runway if the sun's going down, hoping the cow doesn't wander out into the the runway as you're coming in.
You're doing a lot of research as part of your academic life now into EMS and LMIC settings.
Yes.
What have you discovered that surprised you, that you've gone, oh well, this is really interesting, or this is very different to coming from and now currently working in a high income country EMS.
Yes. There's a couple of fascinating things. Now, there's growing research around community first responder programs, and that's certainly something that I have a passion about. Interestingly, lots of the research around these community first responder programs are coming out of sub-Saharan African countries. And what's interesting with those particular countries is that they're typically in larger urban settings that have developed transport infrastructure. And lots of these programs are looking at training taxi drivers and transport drivers as they'll be the first person that turns up on the scene of an accident. So having that, first aid training is really important in those contexts. Vanuatu is different. Like you said, there are 83 islands, and some of those islands don't have roads or cars. I remember some of the patients we would pick up, they got to the clinic on the back of a horse, and then from the clinic to Luganville was on a boat. In some of those African countries where they've got developed transport infrastructure, yes, the context is right. Teach police, teach taxi drivers and transport drivers first aid, because road trauma is one of the biggest causes of morbidity and mortality. Countries like Vanuatu, and I imagine other smaller Pacific Island countries, that will be a different context. We can't train transport drivers because there are no transport drivers. And research shows that, most first aid emergencies occur in the home. So teaching people who in the villages first aid is probably the most logical step. One of the other really interesting things I found, well-meaning organizations come in and go, yes, we're going to do a first aid training program. Excellent. And they design it and they use either a US or an Australian or a UK model, and they teach it. And what I found fascinating was, in some instances, there wasn't a lot of input from the end user. Like, what is this contextually and culturally appropriate? Are we being taught things that we actually need? So I found that very interesting. A side note to that was lots of these programs were taught in English with a translator. Doctor or paramedic or nurse from the US would come and stand in front of the group in English, and then the translator would then translate it into the local language. Look, ideally, any attempt at teaching first aid is great, but to me, putting it into that context and cultural appropriateness, getting someone from your community to teach, I feel, would lead to a stronger link. And then the last thing, and this is the basis of my PhD, is the vast majority of these community first responder programs are being taught in isolation. I'm guilty of that with my community first responder program. I came in, I taught 200 people first aid. Excellent, no worries. It was done in isolation, and then essentially we leave, and that's the end of it. There's limited discussion around how do we integrate these community first responder programs into the established health system. Can we use community first responders as the first tier in the continuum of care?
There's been lots of discussion over the years about first responder programs in Mongolia and stopping the bleed by police and all those sorts of things. However, a good proportion of the population's nomadic, and they're way off the beaten track. They're nowhere near roads. They're nowhere near somebody who can get to them with a vehicle, even with a motorbike, let alone anything else. And they have these very difficult seasons of very harsh winters, which basically they're completely isolated. So the challenge there is how do you provide emergency care to a nomadic community spread across Mongolia? It's very difficult. The first responder program is not the answer.
No, and I guess that comes back to that whole point of context. Is the first responder model the most appropriate? And then I think this is a great question, because I think Australia and potentially other higher income countries are struggling with this at the moment as well. If we look at out of hospital care, is what is the future role of paramedicine? Like, I know in Australia and New Zealand and the US and UK, we're looking at community paramedicine and moving paramedics into the community. Maybe this is the discussion that low and middle income countries need to also look at, is, well, what is the role of a paramedic and how does that fit into our local context?
I'd be interested in your views on this, and we'll wrap up in a minute. But there's a move in Australia, as you know, for paramedics to be able to prescribe, similar to a doctor, to ease the burden on GPs and so on. The argument that we had from one of the post-Soviet nations that run ambulance based on doctor staffing, although they run a dual model, they also do paramedics as well, is cost of training paramedics to prescribe and adding that onto their training time is actually not justified in some degrees. It's better to have a doctor do that work because they're already qualified in the area. What's your view around that? I mean, would you have liked your paramedics in Vanuatu to be able to prescribe, considering there might not be a doctor on the island or available, and they can actually provide penicillin or provide antibiotics for a UTI or whatever the case is?
The context in Vanuatu, 100% yes. My research shows that there were 0.8 doctors per 10,000 population in Vanuatu. And that's the two big centres like Port Vila and Luganville. Once you get out onto those smaller islands, there are no doctors at all. Yes, paramedics in that context, I think, yes. And we don't have to go, big scheduled drugs, but simple drugs like antibiotics. One of the big, causes of morbidity and mortality in Vanuatu is sepsis, particularly from skin wounds and burns. So having the ability to prescribe antibiotics for skin infections and wounds, yes, very important. Mobile phone and communication in Vanuatu is not great, but even having that ability to link in with telehealth, particularly for those outer islands, would be important too. It also comes back to trust in the profession too. I don't think government knows what we do sometimes. And I think the same in Vanuatu. The government didn't really know what we did. Governments spend lots of money on public health and public health initiatives, but the evidence shows that good quality out-of-hospital care can also reduce morbidity and mortality, but not a lot of money is spent on out-of-hospital care.
Just finally, you've got a great deal of experience both in the field and study-wise and academic-wise. What would be your advice to a country or a community if they wanted to set up an effective EMS in a low-resource setting? What would be a couple of things you think would be priority to consider before you take that first step of getting things organised?
Great question. I think the first step is you've got to have buy-in. And I think community buy-in, obviously if they're thinking about it, there's buy-in, but you need that buy-in from all parts of the community. So understanding why you also want the out-of-hospital care system as well. Like, what's the need? Is it lack of access to healthcare in your local context? So do you need transport to get to the clinic or the hospital? And then looking at the types of injuries and illnesses and that are affecting the community that they need that out-of-hospital care. And then developing local contextual guidelines. Transporting in a high-income system is not going to work in most contexts. There's no infrastructure for communications. Vehicles and ambulances could be really expensive. Understanding where you're getting your money from as well is super important too. So when we went to Vanuatu, I was very naive in the way we set it up. And I understand that communities may want to get things done quickly, but I think that preparation time and understanding the need is really important before you jump in with a high income system in a low resource settings. And then something we haven't really covered on is also like governance and ensuring that there are really strong systems around whatever you build.
Andrew, fascinating to talk to you. Terrific insights into Vanuatu and your experiences. I do thank you for your honest reflections. They teach a lot when you also talk about the things that were hard to do rather than just all the successes. So I appreciate your time for that. And Andrew, best of luck with your PhD.
Thanks, Hamish. Really appreciate the time.
If you're enjoying this, consider subscribing so you don't miss future episodes.